Hi, my name is Vicus Pretorius and I will be discussing shoulder dystocia. Shoulder dystocia is an obstetric emergency associated with birth trauma and a risk of newborn permanent disability. It occurs in 0.2 to 3% cases of vaginal birth. It is diagnosed when failing to deliver the fetal shoulders with a normal downward traction and a delay of head to shoulder delivery of more than 60 seconds. Additional maneuvers are then required to deliver the baby. Shoulder dystocia occurs during vaginal birth when the fetal shoulders are impacted behind the symphysis pubis. A delay in first and second stage labor is one indicator, but a more prominent feature is head bobbing or turtle sign when the head retracts towards the perineum after delivery of the fetal head. Pre-hospital management always starts with safety of yourself, the scene, your colleagues, and the patient. Observe delivery is imminent. You need to prepare for normal vaginal delivery. Ensure that you have all your PPE correct. You have all clean towels, cord clamps, neonatal resuscitation equipment. The second stage of delivery begins with full dilation. Mother will have an urge to push, crowning, continue the birth of the head, but there's an inability to birth the shoulders, even if you apply a minimal downward traction. You also observe then head bobbing or turtle sign. Once you recognize shoulder dystocia, do not ask the patient to push, do not apply fundal pressure, do not panic. Assist delivery of the fetus with maneuvers to mitigate risk of injury to mother and infant. Our goal is safe delivery before neonatal asphyxia and or cortical injury. Various mnemonics are used by clinicians to remember the different types of maneuvers. One example is helper mnemonic. I added an S to include the new shoulder shrug maneuver. There is no preferred maneuver. However, paramedics must exhaust all external maneuvers first before undertaking any internal maneuvers. Okay, the first maneuver that I want to demonstrate is the McRoberts maneuver. It's safe, it is simple, and is very effective. And used alone, it can solve about 40% of all shoulder dystocia cases. So basically the legs of the maternal mother hyperflex, so pushed it back against the abdomen. It brings the pelvic inlet and outlet into more vertical alignment. Also straightens the sacrum. It elevates the anterior shoulder and flexes the fetal spine, and also increases the amplitude of contractions. So the second maneuver that I want to demonstrate is suprapubic pressure. Now you have the symphysis pubis, and you want to apply pressure just on the shoulder, not on the fundus. So just behind the symphysis pubis, you will press on the shoulder with a rocking motion. That will help dislodge the shoulder so that the baby can come out. This external maneuver is usually done with the McRoberts maneuver with an success rate of up to 60%. The third maneuver that I want to demonstrate is the Gaskin maneuver. It's also an external maneuver. You ask the mother if she can turn onto all fours with the back arched. The position widens the pelvic outlet and aids assistance of gravity, which may dislodge the fetus shoulder by itself during the position change. A gentle downward traction to the shoulder against the maternal sacrum or upward traction on the shoulder against the maternal symphysis is used to deliver the fetus. All the internal maneuvers can be done in this position if the mother can tolerate it. So the next maneuver I want to demonstrate is the Rubens 2 maneuver. Placing the fingers inside the vagina on the dorsal surface of the posterior shoulder of the fetus and pushing it towards the chest. This will lead to adduction of the fetal shoulder, which would then allow the anterior shoulder to rotate and deliver from behind the pubic bone where it is impacted. Just to explain again, it's basically enter your fingers into the vagina, apply pressure on the posterior aspect of the shoulder and push towards the chest, and that will dislodge the impacted shoulder. The next maneuver that I want to demonstrate is the Woods corkscrew maneuver. Insert the hand into the posterior vagina and rotate the posterior shoulder clockwise or anti-clockwise, like that, and the baby can be born. Okay, just to demonstrate, so the posterior shoulder, the anterior, and 180 degrees rotation. If that doesn't work, you can do it the opposite direction. The next maneuver that I want to demonstrate is the Barner maneuver. It is performed by extracting the posterior arm when your fingers slide along the posterior shoulder and the arm of the fetus, grasping the fetal wrist and sweep it across the anterior to deliver the posterior arm. So just to explain, enter the vagina and go down with the arm until you feel the arm. You can flex the arm, grab the wrist and pull it toward the chest, in front of the chest and down. Then you can assist with a bit of downward pressure to deliver the baby. The next maneuver that I want to demonstrate is the shoulder shrug technique. It is a new and therefore not yet described in current textbooks. It is performed by flexing the neck toward the anterior shoulder and slide the hand behind the posterior shoulder. Clamp the thumb and index finger around the posterior shoulder. With the thumb and index finger form a pincer grip through the axilla. Then retract the posterior shoulder toward the shrug position. Restore the head toward the body's axis to form the head-shoulder unit. Then retract the posterior shoulder toward the shrug position. Restore the head toward the body's axis to form the head-shoulder unit, and rotate this 100. Assess and manage the baby's condition as required. Initiate early resuscitation if indicated to ensure best survival outcome. The newborn baby needs to be dried, kept warm. You need to provide skin-to-skin contact that will help with the release of oxytocin and delivery of the placenta. We need to do an APGAR score to 1 minute and repeat it after 5 minutes. We can clamp and cut the cord after it stopped pulsating. We also need to monitor the mother if there's any postpartum hemorrhage. We obviously would like to get the IV secure as soon as possible. We're not going to wait for the placental delivery. Prepare to transport the mother and newborn to an appropriate obstetric facility for further evaluation. We will obtain and record the vital signs of both patients and repeat en route as often as the situation indicates. Always be ready and calm while dealing with shoulder dystocia. Know your maneuvers and exhaust external maneuvers before doing any internal maneuvers. Precise documentation, including timing, is required, as this may help with future research and for medical legal reasons. Thank you for watching.